During a comprehensive ocular history, a patient reports episodes of blurred vision, particularly when reading, and occasional flashes of light. They also have a family history of retinal detachments. Discuss the potential systemic conditions that may be contributing to these ocular symptoms. What steps should be taken in the history-taking process to further evaluate these concerns? Answer: the patient's symptoms of blurred vision and flashes of light may indicate a variety of potential ocular and systemic issues, including but not limited to vitreous detachment, retinal tears, or migraines. In the history-taking process, the following systemic conditions should be considered due to their ocular implications: diabetes mellitus. Patients with diabetes are at increased risk for diabetic retinopathy, which can cause visual disturbances. History should include asking about recent blood sugar control and duration of the disease. Hypertension. Systemic hypertension can lead to changes in the retina and affect vision. It is crucial to obtain information regarding blood pressure management and any related cardiovascular issues. Family history of eye diseases. Given the patient's rapport of retinal detachments in the family, probing deeper into the specific hereditary conditions, e.g., Marfan syndrome, may reveal a genetic predisposition that warrants further investigation. The clinician should conduct a thorough symptom assessment, inquire about any systemic diseases, and consider referrals for genetic counseling if applicable. Explain the importance of using both direct and indirect ophthalmoscopy during a comprehensive eye examination. What are the advantages and disadvantages of each method? Answer: both direct and indirect ophthalmoscopy are crucial for a complete ocular examination, particularly in assessing the retina and optic nerve. Direct ophthalmoscopy advantages: provides a magnified view of the fundus, allowing detailed examination of the optic disc, macula, and blood vessels. Easier to perform in a primary care setting due to its portability and simplicity. Disadvantages: limited field of view and depth perception, which can make it difficult to evaluate the peripheral retina. Requires the examiner to be in close proximity to the patient, which may be uncomfortable. Indirect ophthalmoscopy advantages: offers a wider field of view and depth perception, facilitating better evaluation of peripheral retinal structures. Allows the examiner to observe the retina from a distance, reducing discomfort for the patient. Disadvantages: typically requires a more skilled technique and can be less intuitive for novice examiners. Less magnification than direct ophthalmoscopy, which can make small details harder to assess. A comprehensive eye examination should incorporate both techniques to maximize diagnostic accuracy. Discuss the role of visual field testing in the diagnosis of glaucoma. What specific techniques are employed, and how do the findings inform clinical decision-making? Answer: visual field testing is a critical component in the diagnosis and management of glaucoma, as it assesses the functional status of the visual pathways, particularly the peripheral vision, which is often affected in glaucoma techniques. Automated perimetry. This method employs a computerized device that presents stimuli in different areas of the visual field to determine thresholds of perception. The results are displayed as a visual field plot, allowing for the identification of scotomas or patterns of visual loss. Confrontation visual fields. A quick, basic test where the clinician compares the patient's peripheral vision to their own. This method is less sensitive but can help screen for gross visual field defects. Clinical decision-making. The findings from automated perimetry can reveal characteristic patterns of visual field loss associated with glaucoma, such as arcuate scotomas or nasal steps. Early detection of these changes is vital for initiating treatment to prevent progression. Tracking visual field changes over time can help determine the efficacy of treatment regimens and whether interventions need to be adjusted. Understanding the significance of these findings can guide clinicians in developing a tailored management plan for patients diagnosed with glaucoma. Mr. Thompson, a 67-year-old man, presents with complaints of difficulty reading and seeing at night. His medical history includes controlled diabetes and hypertension. Upon examination, he exhibits signs of cataracts. What steps should Mr. Thompson take regarding his condition, and what factors should be considered before proceeding with cataract surgery? Answer: Mr. Thompson should first consult with an ophthalmologist to discuss the impact of his cataracts on his quality of life and daily activities. The decision to proceed with cataract surgery should consider the following factors: visual impairment assessment. The extent to which cataracts are impairing vision and affecting daily activities should be evaluated. The patient's functional vision is a key determinant in the decision-making process. Systemic conditions. Mr. Thompson's diabetes and hypertension require careful management before surgery. The ophthalmologist should assess the stability of his systemic conditions, as uncontrolled diabetes can increase surgical risks and impact healing. Patient preferences. Mr. Thompson's preferences regarding surgical intervention, potential outcomes, and risks associated with surgery must be considered. An informed discussion about the benefits and risks of surgery, including possible complications, is essential. Timing of surgery. Given Mr. Thompson's age and systemic conditions, the ophthalmologist may recommend monitoring his cataracts periodically before proceeding with surgery if they are not significantly impacting his quality of life. Describe the role of optical coherence tomography (OCT) in evaluating retinal diseases. What are the key advantages of using OCT compared to traditional imaging techniques? Answer: optical coherence tomography (OCT) is a non-invasive imaging technique that provides high-resolution cross-sectional images of the retina, allowing for detailed evaluation of retinal structures. Role in evaluating retinal diseases. OCT is pivotal in diagnosing and monitoring conditions such as diabetic retinopathy, age-related macular degeneration, and retinal detachment. It helps visualize retinal layers, allowing clinicians to assess the integrity of the retinal nerve fiber layer and the presence of fluid or edema. Advantages of OCT: high resolution. OCT provides detailed images with micron-level resolution, enabling the detection of subtle changes in retinal architecture that might be missed by traditional fundus photography. Non-invasiveness. Unlike fluorescein angiography, OCT does not require intravenous dye injection, minimizing risks associated with contrast media. Real-time imaging. OCT allows for real-time assessment, facilitating prompt diagnosis and treatment decisions. Explain the significance of pupillary reaction testing in the context of a neurological assessment. What are the different types of pupillary reactions and what do they indicate about the patient's neurological status? Answer: pupillary reaction testing is a crucial component of a neurological assessment as it provides insight into the integrity of the afferent and efferent pathways of the visual system. Types of pupillary reactions. Direct reaction: the constriction of the pupil in response to light directly entering the eye. An intact direct response indicates a functioning optic nerve and midbrain pathways. Consensual reaction: the constriction of the opposite pupil when light is shone in one eye. This reaction assesses the interconnections between the two hemispheres of the brain. Relative afferent pupillary defect (RAPT), a clinical sign indicating a defect in the sensory input of one eye. When swinging a light from the unaffected eye to the affected eye, the affected eye shows less constriction, suggesting a compromise in the afferent pathway. Neurological implications: an abnormal direct or consensual response may indicate lesions in the optic nerve or brainstem. The presence of an APD suggests an underlying pathology, such as glaucoma or retinal detachment, that warrants further investigation. What are the critical elements of a comprehensive slit lamp examination, and how do they contribute to the evaluation of anterior segment diseases? Answer: a comprehensive slit lamp examination is essential for evaluating the anterior segment of the eye, including the cornea, anterior chamber, iris, and lens. The key elements include corneal assessment. The examination of the cornea involves looking for opacities, scars, or edema. Conditions like keratitis or corneal dystrophies can be diagnosed through detailed observation. Anterior chamber evaluation: the depth and clarity of the anterior chamber are assessed. Presence of cells or flare can indicate inflammation, as seen in uveitis. Iris examination: the slit lamp allows for detailed evaluation of the iris for any abnormalities such as neovascularization or lesions. Lens assessment: the examination includes checking for cataracts or other opacities in the lens that could impair vision. Each of these elements contributes to a holistic understanding of anterior segment health and aids in diagnosing conditions that may require intervention. Discuss the significance of electroretinography (ERG) in the evaluation of retinal function. How does it differ from visual acuity testing in terms of diagnostic capability? Answer: electroretinography (ERG) is an essential diagnostic tool used to assess the electrical activity of the retina in response to light stimuli, providing valuable information about retinal function. Significance of ERG: ERG is particularly useful in diagnosing inherited retinal dystrophies such as retinitis pigmentosa and conditions affecting retinal function such as diabetic retinopathy. It evaluates both rod and cone photoreceptor function, allowing for differentiation between various retinal pathologies. Comparison with visual acuity testing. Visual acuity testing primarily assesses the clarity of vision and the ability to discern shapes and details at specific distances. It does not provide information about the underlying retinal function. It measures the actual electrical responses of retinal cells, enabling detection of dysfunction even in the presence of normal visual acuity. For instance, a patient may have a normal visual acuity yet exhibit abnormal RG results indicating retinal disease. Describe the significance of color vision assessment in a comprehensive ocular examination. What tests are typically used and what underlying conditions can affect color perception? Answer: color vision assessment is a vital component of a comprehensive ocular examination as it provides insights into the functioning of the cones in the retina, essential for color discrimination. Tests for color vision: Ishihara plates. The most common test for red-green color deficiencies, utilizing patterns of colored dots to assess the patient's ability to distinguish colors. Farnsworth D15 test, a more detailed evaluation of color discrimination where patients arrange colored caps in order of hue. Conditions affecting color perception. Color vision deficiency at CVD. Inherited conditions such as red-green color blindness affect the ability to perceive specific colors. Cataracts. The presence of cataracts can lead to a yellowing of the lens, affecting color perception, particularly blues and greens. Optic nerve disorders. Conditions such as optic neuritis can disrupt color vision due to damage in the optic nerve pathways. Explain the role of fluorescein angiography in the assessment of retinal vascular conditions. What are the key indications for this diagnostic procedure? Answer: fluorescein angiography is a vital diagnostic tool used to visualize the retinal and choroidal circulation, aiding in the assessment of various retinal vascular conditions. Role of fluorescein angiography. The procedure involves injecting fluorescein dye intravenously, which highlights the blood vessels in the retina when viewed through a specialized camera. It allows for the evaluation of blood flow, leakage, and vascular abnormalities, crucial in diagnosing conditions such as diabetic retinopathy, age-related macular degeneration, and retinal vein occlusion. Key indications: diabetic retinopathy, to assess the extent of vascular changes and guide treatment decisions; age-related macular degeneration, to evaluate choroidal neovascularization, which may require anti-VEGF therapy; retinal vascular occlusions, to determine the degree of ischemia and guide management strategies. Discuss the role of the cornea in vision and explain the pathophysiology of keratoconus. How does this condition affect visual acuity and what are the potential treatment options? Answer: the cornea is the transparent, dome-shaped structure that covers the front of the eye. It plays a crucial role in focusing light onto the retina, accounting for approximately 2/3 of the eye's total optical power. The cornea is made up of 5 layers: the epithelium, Bowman's layer, stroma, Descemet's membrane, and the endothelium. Each layer contributes to its structural integrity and function. Keratoconus is a progressive disorder characterized by the thinning and conical shape of the cornea, leading to regular astigmatism and myopia. The exact etiology is not well understood, but it is believed to involve genetic, environmental, and biochemical factors. The thinning of the cornea results in a distorted refractive surface which can significantly impair visual acuity. Patients often experience increased sensitivity to light and distorted images. Treatment options vary based on the severity of the condition. Early stages may be managed with rigid gas-permeable contact lenses to improve vision. As the disease progresses, interventions such as corneal cross-linking to strengthen the corneal tissue, intact intrastromal corneal ring segments, or even corneal transplantation may be necessary to restore visual function. Explain the phototransduction process in rods and cones, highlighting the differences in sensitivity to light and response to color. Answer: phototransduction is the process by which photoreceptor cells, rods, and cones convert light into electrical signals. In the rods, which are responsible for vision in low light conditions, the photopigment rhodopsin undergoes a conformational change when it absorbs photons. This change activates a series of biochemical reactions, ultimately leading to the closure of sodium channels, hyperpolarization of the cell, and the cessation of neurotransmitter release. Rods are highly sensitive to light but do not contribute to color vision. In contrast, cones operate in brighter light and are responsible for color vision. There are 3 types of cones, each containing a different photopigment. S cones, short wavelengths, blue; M cones, medium wavelengths, green; and L cones, long wavelengths, red. When photons strike these cones, similar biochemical changes occur, but the resulting signals differ based on the type of cone activated. The difference in sensitivity is primarily due to the distribution of these photoreceptors across the retina. The rods are concentrated in the peripheral regions, while cones are densely packed in the fovea. This arrangement explains why we have poor color vision and decreased visual acuity in dim light. Describe the anatomy of the retina, focusing on the macula and fovea. What are the implications of damage to these structures on visual function? Answer: the retina is a thin layer of tissue located at the back of the eye that contains photoreceptors, supporting cells, and ganglion cells. It is divided into 2 main areas: the peripheral retina, which contains mostly rods, and the macula, which is responsible for central vision. The macula is a specialized region about 5 millimeters in diameter and is further divided into the fovea centralis, the area of the highest visual acuity due to its high density of cones. Damage to the macula or fovea, as seen in conditions like macular degeneration or diabetic retinopathy, severely impairs central vision, affecting activities such as reading and recognizing faces. The loss of photoreceptors in these areas leads to a central scotoma, a blind spot in the center of vision, while peripheral vision may remain intact, resulting in a characteristic tunnel vision effect. Mr. Smith, a 65-year-old patient, presents with complaints of increasing eye pain and halos around lights. Upon examination, you find elevated intraocular pressure and a shallow anterior chamber. What condition might Mr. Smith be experiencing, and what immediate actions should be taken to manage his condition? Answer: Mr. Smith's symptoms and examination findings are indicative of acute angle closure glaucoma, a condition characterized by a sudden increase in intraocular pressure due to the blockage of aqueous humor outflow. The shallow anterior chamber suggests that the iris is being pushed forward, occluding the tracheal meshwork. Immediate management includes administering medications to lower intraocular pressure, such as topical beta blockers, e.g. timolol alpha agonists, e.g. aproclonidine, or carbonic anhydrase inhibitors, e.g. dorzolamide. Oral medications like acetazolamide may also be used. In addition, topical hyperosmotic agents, e.g. mannitol, can be given to reduce fluid volume. After stabilizing the patient, definitive treatment involves laser peripheral iridotomy or surgical intervention to create an opening in the peripheral iris, allowing aqueous humor to flow freely and alleviate pressure in the anterior chamber. Discuss the structure and function of the optic nerve and explain how disorders affecting this nerve can lead to specific visual field defects. Answer: the optic nerve cranial neuromentum is formed by the axons of ganglion cells in the retina, which converge to form a bundle that exits the eye at the optic disc. It is responsible for transmitting visual information from the retina to the brain. The optic nerve is surrounded by protective sheaths that provide structural support and insulation, and it consists of approximately 1.2 million nerve fibers. Disorders affecting the optic nerve can lead to specific visual field defects. For instance, damage to the optic nerve can result in a complete loss of vision in the affected eye, monocular blindness, or lead to more complex visual field deficits. An example is the bitemporal hemianopsia, often seen in pituitary tumors where peripheral vision in both eyes is lost, leaving central vision intact. Alternatively, damage to the optic nerve on one side can lead to homonymous hemianopsia, where the same side of the visual field is lost in both eyes. These visual field defects highlight the importance of the optic nerve in the visual pathway and underscore the need for prompt diagnosis and treatment of any conditions that compromise its integrity. Explain the process of accommodation in the human eye. How does this process change with age, and what implications does this have for presbyopia? Answer: accommodation is the process by which the eye changes its focus from distant to near objects, primarily involving the lens. When viewing distant objects, the ciliary muscles relax, causing the lens to flatten. In contrast, when focusing on near objects, the ciliary muscles contract, allowing the lens to become more rounded due to its elastic properties, thereby increasing its optical power. With age, the lens becomes less flexible and more rigid, reducing its ability to change shape effectively. This condition is known as presbyopia, which typically becomes noticeable in individuals around the age of 40. As the result, tasks requiring near vision, such as reading, become more challenging, leading to the need for reading glasses or bifocals to assist with focusing on close objects. Understanding the mechanism of accommodation and the changes that occur with aging is crucial for diagnosing and managing presbyopia in clinical practice. Discuss the composition and function of the tear film. How do abnormalities in tear film production affect ocular health? Answer: the tear film is a complex fluid that covers the surface of the eye, consisting of 3 layers: the lipid layer, the aqueous layer, and the mucin layer. The lipid layer, produced by the meibomian glands, prevents evaporation of the aqueous layer. The aqueous layer, secreted by the lacrimal glands, provides hydration, nutrients, and antimicrobial properties. The mucin layer, produced by goblet cells in the conjunctiva, facilitates the adhesion of the tear film to the cornea. Abnormalities in tear film production can lead to dry eye syndrome, keratoconjunctivitis sicca, which may result in symptoms such as burning, redness, and blurred vision. Chronic dry eye can lead to corneal damage, increased risk of infection, and reduced quality of life. Treatment options may include artificial tears, anti-inflammatory medications, and punctual plugs to enhance tear retention and restore ocular surface health. Describe the visual pathway from the retina to the visual cortex, including key structures involved in the processing of visual information. Answer: the visual pathway begins with the photoreceptors in the retina rods and cones that convert light into electrical signals. These signals are transmitted via the bipolar cells to the ganglion cells, whose axons form the optic nerve. The optic nerve exits the eye at the optic disc and travels towards the brain at the optic chiasm. The optic nerves from both eyes partially cross at fibers from the nasal retina. Temporal visual field cross to the opposite side, while fibers from the temporal retina remain ipsilateral. This arrangement allows for binocular vision and depth perception. After the chiasm, the optic tracts carry the visual signals to the lateral geniculate nucleus (LGN) of the thalamus. From the LGN, visual information is relayed through the optic radiations to the primary visual cortex, located in the occipital lobe. Here, the brain processes various aspects of vision, including orientation, color, motion, and depth, ultimately leading to visual perception. Understanding the intricate pathway of visual processing is vital for diagnosing and treating visual disorders, as damage to any part of this pathway can result in specific visual field defects and perceptual challenges. Explain the anatomy and function of the extraocular muscles. How can dysfunction of these muscles affect eye movement and alignment? Answer: the extraocular muscles consist of 6 muscles that control eye movements: the superior rectus, inferior rectus, medial rectus, lateral rectus, superior oblique, and inferior oblique. Each muscle is innervated by specific cranial nerves. The oculomotor nerve, through the trochlear nerve romana, and the abducens nerve romans. So the muscles work together to facilitate complex movements such as adduction, abduction, elevation, and depression of the eye. Dysfunctions, such as those seen in strabismus, misalignment of the eyes, can arise from imbalances in muscle strength or innervation, leading to double vision or decreased depth perception. In cases of paralysis of specific muscles, such as in the third cranial nerve, palsy, the affected eye may deviate downwards and outwards, reflecting the unopposed action of the lateral rectus and superior oblique muscles. Understanding the anatomy and function of the extraocular muscles is essential for diagnosing and managing ocular motility disorders, ensuring appropriate treatment to restore proper alignment and binocular function. MS Johnson, a 30-year-old woman, presents with proptosis of the right eye and decreased visual acuity. Imaging reveals a mass in the right orbit. What differential diagnosis should be considered and what steps should be taken to manage her condition? Answer: MS. Johnson's presentation suggests a possible orbital mass which could be due to various conditions. Differential diagnoses include orbital tumors, such as meningioma, lymphoma, or metastatic lesions, inflammatory conditions like thyroid eye disease, Graves' disease, or orbital pseudotumor, vascular lesions, including arteriovenous malformations or orbital hemorrhage. Management begins with a thorough clinical examination, including visual acuity testing and assessment of ocular motility. Imaging studies such as MRI or CT scans are essential for characterizing the mass and determining its extent in relationship to surrounding structures. Depending on the findings, treatment may involve surgical intervention, especially if the mass is compressive or poses a threat to vision. If an inflammatory process is suspected, corticosteroids may be indicated. Continuous monitoring and follow-up are crucial to assess response to treatment and manage any complications that may arise. Explain the pathophysiology of myopia and discuss the current surgical options available for its correction, including their indications and potential complications. Answer: myopia, or nearsightedness, occurs when the eyeball is too long relative to the refractive power of the cornea and lens, causing light rays to focus in front of the retina. This condition can be attributed to genetic factors and environmental influences, such as prolonged near work. Surgical correction options for myopia include laser-assisted in situ keratomolysis (LASIK). This procedure reshapes the cornea using laser technology. Indications include stable myopia of -0.5 to -12.0 diopters with a target correction within the patient's refractive range. Complications can include dry eye syndrome, undercorrection or overcorrection, and flap-related issues. Photorefractive keratectomy (PRK), similar to LASIK but involves removing the outer corneal epithelium before reshaping the cornea. It is suitable for patients with thinner corneas. Postoperative complications include pain during recovery, haze formation, and delayed vision stabilization. Intraocular lenses (IOLs). For high myopia, phakic IOLs can be implanted. These lenses are positioned in front of the natural lens and do not require corneal alteration. Possible complications include cataract formation, lens dislocation, and increased intraocular pressure. Describe the clinical presentation and management options for age-related cataracts. What postoperative complications should be monitored? Answer: age-related cataracts commonly present with gradual vision loss, increased glare, and difficulty with night vision due to the opacification of the lens. Patients may experience changes in their refractive error, often leading to myopia. Management options include surgical intervention. Phacoemulsification is the most common technique, where an ultrasonic device breaks up the cataract, allowing for the removal of lens fragments and the implantation of an IOL. The choice of IOL, monofocal, multifocal, toric, depends on the patient's visual needs and lifestyle. Postoperative complications to monitor include endophthalmitis, a severe infection that can occur post-surgery. Symptoms include redness, pain, and decreased vision. Prophylactic measures such as topical antibiotics can reduce the risk. Posterior capsule opacification (PCO). This is the most common complication post-cataract surgery, presenting with a recurrence of visual symptoms similar to those experienced before surgery. Treatment involves a Y8G laser capsulotomy to clear the opacified capsule. A 58-year-old patient presents for a routine eye examination. Upon testing, their intraocular pressure eye is measured at 24 mmHg. Discuss the implications of this finding, including potential diagnosis, risk factors for glaucoma, and initial management strategies. Answer: an IOP of 24 mmHg is elevated and raises suspicion for glaucoma, particularly primary open-angle glaucoma. POG risk factors for developing glaucoma include advanced age, family history of glaucoma, African or Hispanic ethnicity, myopia, and a history of ocular trauma. Initial management strategies include medical management. Topical prostaglandin analogs e.g. latanoprost are often the first line of treatment as they increase aqueous outflow. Other options include beta blockers e.g. timolol and alpha agonists e.g. brimonidine, each with specific side effects that must be considered monitoring. Regular follow-up appointments should be scheduled to monitor IOP, visual field testing, and optic nerve head evaluation for signs of progression. Surgical options: if medical therapy fails to achieve target IOP levels, surgical options such as trachelectomy or minimally invasive glaucoma surgery may be indicated to facilitate aqueous outflow and lower IOP. Explain the classification and management strategies for diabetic retinopathy. How does the presence of macular edema influence treatment options? Answer: diabetic retinopathy is classified into two main stages: non-proliferative diabetic retinopathy (NPR), characterized by microaneurysms, retinal hemorrhages, and exudates. Management focuses on controlling blood glucose levels, blood pressure, and lipids. Proliferative diabetic retinopathy (PDR). This stage involves neovascularization, which can lead to vitreous hemorrhage and retinal detachment. Management strategies include laser photocoagulation. Panretinal photocoagulation (PRP) is indicated to reduce the risk of severe vision loss. Anti-VEGF injections, such as ranibizumab or aflibercept, are effective for managing diabetic macular edema (DME), which often complicates PDR. Macular edema significantly affects vision and is treated with anti-VEGF therapy or corticosteroids if persistent. Early detection through regular screening and timely intervention can preserve vision and reduce the risk of severe visual impairment. A 45-year-old female patient presents with symptoms of persistent dryness, burning, and fluctuating vision. Discuss the diagnostic criteria for dry eye disease (DED) and outline the stepwise management approach. Answer: dry eye disease is diagnosed based on symptoms and objective tests. The key symptoms include dryness, irritation, and visual fluctuations. Objective tests include Skirmer's test, measures tear production with values 10 mm, considered indicative of D tear breakup time, T but less than 10 seconds indicates poor tear. Stability stepwise management includes initial therapy, artificial tears, and lubricating ointments to alleviate symptoms. Preservative-free options are recommended for frequent use. Intermediate therapy. Puntal plugs may be used to reduce tear drainage and improve ocular surface moisture. Advanced therapy. Prescription medications like cyclosporine or Restosys or Lifigrast, Zidra can enhance tear production and reduce inflammation. Patient education on lifestyle modifications, including the use of humidifiers and taking breaks during screen time, is crucial for effective management. Regular follow-up is necessary to assess treatment efficacy and adjust the management plan accordingly. Mr. Thompson, a 60-year-old male, reports sudden onset of flashes and floaters in his right eye, followed by a shadow in his peripheral vision. What are the potential diagnoses and the appropriate immediate actions he should take? Answer: Mr. Thompson's symptoms are highly suggestive of a retinal detachment, which can present with photopsia flashes and the perception of floaters, often followed by a shadow or curtain effect in the peripheral vision. The immediate actions include referral to an ophthalmologist. Prompt evaluation is essential as retinal detachment is a sight-threatening emergency. Imaging. The ophthalmologist may perform a dilated fundus examination and potentially optical coherence tomography to confirm the diagnosis and assess the extent of the detachment. Treatment options. If confirmed, surgical intervention is necessary, with options including pneumatic retinopexy, scleral buckle, or vitrectomy depending on the type and location of the detachment. Mr. Thompson should be instructed to avoid physical exertion and keep his head in a specific position as advised by the ophthalmologist until he can receive care. Discuss the implications of coexisting ocular conditions, such as diabetic retinopathy in a patient undergoing cataract surgery. How should the surgical approach be modified? Answer. In patients with diabetic retinopathy, cataract surgery poses specific challenges due to the risk of intraoperative complications, such as bleeding or retinal detachment. The implications include preoperative assessment. A thorough evaluation of the extent of diabetic retinopathy is critical, including fundus examination and OCT. This determines the need for simultaneous treatment of retinopathy during cataract surgery. Surgical approach. Techniques such as careful capsule or hexis and avoiding excessive manipulation of the eye are essential to minimize the risk of vitreous loss or hemorrhage. In cases of severe retinopathy, the surgeon may consider performing retinal laser photocoagulation before cataract surgery. Postoperative management. Close monitoring for signs of macular edema or progression of retinopathy after surgery is important. Patients should be counseled on the importance of blood glucose control and regular follow-ups to manage both conditions effectively. Explain the mechanism of action and clinical implications of prostaglandin analogs in the management of glaucoma. What are the common side effects to monitor? Answer. Prostaglandin analogs, such as latanoprost, work by increasing aqueous humor outflow through the uveoscleral pathway. They are often the first-line therapy for glaucoma due to their efficacy in lowering intraocular pressure and once-daily dosing convenience. Clinical implications include efficacy. These agents can lower IOP by 2.5–3.5%, making them effective for managing various types of glaucoma. Side effects. Common side effects include hyperemia, redness of the eye, eyelash growth and pigmentation changes of the iris, darkening of the eyelid. Skin. Patients should be monitored for these side effects, and education regarding potential cosmetic changes is important to ensure adherence to treatment. Regular IOP checks are necessary to evaluate the effectiveness of therapy and make adjustments as needed. A 70-year-old woman presents with severe ocular pain, headache, nausea, and vision changes. Her IOP is measured at 5th mHg. Discuss the likely diagnosis, immediate management, and long-term treatment options. Answer. The presentation is consistent with acute angle closure glaucoma, which occurs when the drainage angle of the anterior chamber is obstructed, leading to rapid increases in IOP. Immediate management includes medications. Carbonic anhydrase inhibitors, e.g. acetazolamide, to reduce aqueous humor production, topical beta blockers to lower IOP, and osmotic agency, mannitol, to draw fluid from the eye. Definitive treatment. After IOP stabilization, laser peripheral iridotomy is the procedure of choice, creating a new drainage pathway for aqueous humor to bypass the obstructed angle. Long-term management. Patients may require ongoing treatment with topical medications or surgery to prevent future episodes, especially if they have narrow angles or a history of angle closure episodes. Regular monitoring of IOP and visual fields is essential in managing these patients. Discuss the management strategies for a patient diagnosed with a choroidal melanoma. What are the prognostic factors and treatment options? Answer. Choroidal melanoma is the most common primary intraocular malignancy in adults, requiring careful management. Key prognostic factors include tumor size. Larger tumors, 3 mm in height and 5 mm in diameter, have a worse prognosis. Location. Tumors located in the posterior segment tend to have a higher risk of metastases. Management strategies include observation. Small tumors with low-risk features may be monitored with regular follow-up imaging. Radiation therapy. Plaque brachytherapy and stereotactic radiation therapy are common treatment options for preserving vision while controlling tumor growth. Enucleation. In cases where there is extensive growth or if the tumor invades surrounding structures, removal of the eye may be indicated to prevent metastases. Prompt diagnosis and intervention are crucial in improving patient outcomes, and multidisciplinary care involving oncologists and radiation specialists is often necessary.